Hi everybody, welcome back to part two. We're talking about health communication planning frameworks today, really leaning into some of the basic structure of how we can plan health communication and where that's nested in the bigger scheme of things. Before we get to anything else though, it's really important to recognize that one size fits all is not a thing in health communication. We cannot just apply the same strategies to every situation. We can certainly look at patterns and strategies that might work, but they all need to be tweaked to meet the nuances of the audiences that we are working with. So much like everything else we talk about in these places, there's a whole lot of different ways to think about these things. So we're looking now at these basic ideas about approaches to planning. These are just three ideas. There are many more out there, although I have to say the CDC energy piece on the end is one of the most popular, likely because it's most accessible. But health communication approaches to planning really vary in the way they've been talked about, although the key components seem to be the same. So if you can see the top one, when looking at what the Public Health Foundation has to say, it's as simple as saying that a strategy to health communication is that we deliver the right message in the right place at the right time to the intended key audience. Obviously that's easier said than done, but that is the overall objective. So one common approach to planning is NOR's ACME. It stands for Audience, Channel, Message, and Evaluation. So that walks us through the steps, and of course there's many layered pieces within each one of those bulleted points. But we start with the audience, of course, or the key audience, determine the channel and the message, and certainly evaluate what's working and what's not working. CDC Energy, this is more focused on social marketing campaigns, which of course is what we lean towards mostly these days. But it breaks it apart in this way: problem description first, so we need to get the lay of the land of what's happening, market research to see what is already available out there, strategies that have worked in the past in similar situations, so it's kind of like a background check or lit review, interventions, and of course evaluation. So even in these two you can see there's a trend that evaluation is a key piece of communication. We need to know, ideally through formative process and outcome evaluations, what's working and why, and what's not working and why. So like everything else, we need to situate health communication in larger context. So when we're talking about communication schemes, as was mentioned in the article you read last week for classes, talking about these multi-layered strategies where they were working with students, working with faculty and staff in the school, working with administrators, and then working with the community. We do have to think about layers that impact and influence what needs to be communicated or whatever behavior we're looking to change or something in the environment. So health communication, like everything else we do, is situated in our ecology, and in this case the ecological model. So we have all these, this is just a revisit of your previously gained knowledge around the ecological model, but we have these nested situations. So each individual obviously is nested within a larger situation, either family, some version of family, school, work, church, community, and we just keep growing and growing and growing. So this just situating health communication in the ecological model helps us to think through all of the reverberating effects. So if we're working just with individuals, we need to think about the context the individual's in and the greater context that they live in. So their community, their neighborhood, and then certainly the political policy systems, societal level influences and reverberations, right? If we change something individual, especially when we're talking about health communication with the potential for advocacy, how will that ripple through to potentially change policies or systems that are impinging on, or in some cases, making room and supporting individuals, and every level in between. This is just a way to map out, this is right out of the Parvanta et al. Book that I had mentioned to you before. This gives some ideas of where in the ecological model things will line up with communication supports with a primary intervention in mind. So we'll just skip to the second one, living and working conditions. The idea of the primary intervention focus might be environmental conditions, hours, policies, so for example worker safety or walking paths, elimination of lead, availability of healthy food. And when you look across there, the communication supports around that would be citizen or worker advocacy to improve conditions, awareness and promotion campaigns, state or local led education campaigns, and the list can go on and on. But this is just a quick little diagram to show you that at each point or each tier of the ecological model, the intervention will look a bit different, or interventions, as will the communication supports that go along with it. So as we've talked about before, health communication campaigns are, generally speaking, not standalone. They are part of a larger effort, and they're often the means by which these things do happen because it's the way we're communicating or raising awareness about it. So take a gander at this, and it's in the textbook. If you want a better look, I can certainly share that with you. So when we're talking about health communication plans and strategies, I want to point out that we are often, in general in life, I would argue, acting in emergency mode, right? Just like freaking out and something has to happen right away. And so we don't necessarily take the time or feel that we have the time to sit down and think through the steps and engage in a drawn-out process, which can take up to a year or more for planning a health communication strategy or a campaign intervention, whatever term you want to use. So we end up in these kind of fast-paced, hurried places, and therefore we end up with things that might not be reflective of what the community needs and or may misfire, right? We might be throwing spaghetti at the wall and it definitely doesn't stick. We might get lucky every once in a while, not to say it doesn't work, but it's certainly not the best way to do it. So planning is key, and having ample time to engage in the process of planning is really key. So we need a plan, right? Short and simple. Health communication, just so we know when we're talking about planning, much like health communication itself, ideally is evidence-based, is research-driven, and grounded in the needs of the key audiences. So the needs, environment, priorities of the very people that we're trying to message to and with. So we know already, but just to reiterate, communication plan can do a lot of things, including advancing the mission of an organization, supporting health and social change. Health communication can be a conduit, can be the go-between for a lot of different things, and ideally the plan for health communication, again, is situated as part of, alongside of, a larger health promotion or health education campaign. So, you know I'm big on this, and again, I think that it sometimes feels like it might be unreachable, but it's something that I want us all to consider, and hopefully something you all would be willing to advocate for when you are in the working community around health communication or health education, health promotion. Participatory planning is a long process, but I would argue it is the most rewarding process. So when I'm talking about participatory planning, I'm talking about people coming together. It's a horizontal democratic process where we're trying to literally flatten the hierarchy so that people are on the same plane, working together, as these multiple hands suggest, recognizing that every person at the table is active and has something valuable to add to their own development and to the development of the strategy. So it recognizes the communal capacity and individual capacity at the same time. This is different than what we see in a lot of different spaces, where we have a couple of folks who are sitting in a removed place from what's actually happening, and they're making decisions for those people, right? This happens in workplaces all the time. It happens in a lot of places. So this might feel uncomfortable for some folks and or unfamiliar anyway. And again, it takes time. If you have participatory planning, that means you have to leave space, literally, leave space and time for people to gather and come together and collectively make decisions. Of course, it's speedier when these few people make decisions for these huge amounts of people. Coming together is a different piece. However, when people have a say in shaping what's happening to them or with them and to their communities, there's more buy-in, there's greater effect, and there's certainly more attention to detail and holding everyone's feet to the fire about what the actual needs are versus what people think the needs are. So although it might feel like a reach and maybe an idealized version of what's happening, it is something that we should strongly consider and advocate for, I would argue. So similarly, like you're going to hear again repeatedly throughout this course, is that we really cannot start anywhere but where the key group is at the time you engage with them, whatever that looks like. You might have epidemiological data that suggests that there are significant issues around diabetes in a particular neighborhood, and therefore you have funding to go and work and support change around healthy behaviors, right? So eating, exercise, groceries, access, you name it. You might have ideas because you have this data that suggests that you need to work on these key pieces. If you go to that community, which you should be going to that community, and hear from them that they need to start somewhere other than one of those 3 or 4 things I just mentioned, then you need to start there. And no, it doesn't mean that you can't suggest that here are some key things that we know affect overall health that would minimize risk for diabetes or help people change behavior so they can lose the diagnosis of diabetes. You still need to start with where they are. If you're trying to push them along somewhere else, somewhere that they feel is not the most pressing need, you've lost them already, and your exercise is futile. And all that time and money will be for very little, if for naught. So just so you have a bigger picture, the health communication planning program planning cycle looks, right, you've seen this circle, it looks much like the research circle, right, how we think about where we start and where we come together, and that it's a cyclical process. So we can start with background literature review, reviewing formative research, and technically end with evaluation, but really it's not an ending. Evaluation is just a new beginning, because then we can refine and tweak and maybe take a different approach depending on what came out of the process. So when we're talking about health communication and program planning cycle, we're really focusing on starting around step 2 here, which is strategy development, behavioral objectives, creative approaches, and audiences. We need to think about all the pieces that will be needed to support the larger effort, this larger circle, so to speak. It's such a key, communication is such a key piece of this ever-going program planning cycle. When you break out stages 2 and 3, which is predominantly where the health communication program cycle lives, we're focusing on planning and strategy development, and then step 2 in the health communication program cycle is developing and pre-testing concepts, messages, and materials. When I'm talking about the program, excuse me, the participatory planning, and talking about keeping with priority needs of the population, there's kind of an in and out process. So if we're coming together with community to understand their needs and think about what strategies might be best, and we come up with a strategy, and then we have these ideas about messaging and concepts and materials, we're kind of coming back to our own little space, our organization, our hub outside of the community, working on those things, and then we have to bring them back to that same audience or the group of stakeholders or whomever to say, is this what, first of all, did we capture what it is you were saying, and can you ask people in your circles to come in and take a look at them or use these materials and solicit feedback? Maybe we had an image in there that doesn't reflect the community. Maybe we have wording in there that might be tweaked to use some of the language that's common in the community but means the same thing. We won't know those things if we don't bring our ideas, our messages and concepts and materials back to the same community and work, right? So it's this kind of give and take process on a regular basis. So from there, once we have concrete, accepted, grounded materials, concepts, messages, then we can move on to implementing the program, and then certainly addressing effectiveness and making refinements. So much like a qualitative research process, there's lots of wiggle room in here. You can go back and change materials, you can implement them again and see if it's missing the boat. You can keep on swinging between stages 2 and 4 as much as needed. Of course, that's an idealized version. Sometimes we don't have that much flexibility in terms of time or funding. However, ideally, there's room to refine the process as you're going through it so that you aren't just kind of shoving an idea down the throats of folks who are saying, this is not what we need or want, right? And then, of course, once we have these looking at effectiveness and looking at both the process and the outcomes, we can then plan and develop the next layer, and the cycle then continues. So within a larger plan, we're going to get into more details in another video. In the larger plan, we have lots of sub-plans related to health communication. Here's a list of some of them. These are not in chronological order, so these things can be happening parallel to one another. But first, of course, we do generally start with a macro plan. This is where we're looking at the problem itself, determining the audience, the behavior change goals, looking at core intervention strategies, and seeing about who the partners might be. This is also a time where we start doing some formative research, trying to dig in to see, yes, we might know the problem again based on epidemiological data, but what does the problem look like, feel like, smell like, taste like for a community? Those are things we're not going to learn from epidemiological data necessarily. We're going to have to go and sit with and learn and do interviews and focus groups and the like with community members. Then, of course, we like stage 2, I just mentioned strategic health communication, where we start pre-testing specific concept messages, materials. Again, more room for formative and process research, so we can start evaluating and looking at how we are doing business in collecting this information. What about the process of this communication planning effort is working or not working? Implementation gives us a very concrete tactical plan. So when we're thinking about a planning piece around implementation, we're talking about what, when, where, how, by whom, budget, who's responsible. Again, another opportunity for process research to see how things are moving along, what's working and what's not working. Evaluation should be planned at the start, right? This evaluation should be in mind from the very minute we start talking about any kind of plan. Especially once we've determined the audience and the behavior change goal, we can start thinking about what are we thinking we want to see, and that can be tweaked as we build these other sub-plans that develop into the larger plan. But evaluation should not be left to the tail end to be like, oh, what data should we have collected? We can do pre, we can do mid, we can do post, we can do lots of different things to look at evaluation, but we're certainly determining what aspects should be monitored, and again, working from baseline before we start until we finish, and then that loop continues. Partnership is essential. I keep on hammering this. When we're talking about shared process, then we have to see who our partners are, and it might not just be community members, it's key stakeholders, it's could be representatives, it could be people from insurance companies, it could be anyone who has skin in the game, right? Who can be useful and is affected by what's happening. So we also have to determine, when we do determine partners, who's responsible for what and what are they contributing. Partnerships get us so much more room and growth out of any given health communication or health program we can think of. It improves longevity, it empowers folks for ownership and leadership, and it makes it altogether more sustainable. And the last piece that is important when we're thinking about any kind of planning is how we're going to share this. There are very similar problems across the nation and arguably across the globe. Obviously, the circumstances and the look and the taste and the feel of those problems will vary by community, particularly by nation. However, sharing the information of how we've done things and what's worked and what didn't is powerful knowledge to someone who's just engaging in their piece of the puzzle with their communities. So it's inherent upon us, I would argue, as an ethical responsibility as community health educators, as public health professionals, to disseminate our work. And that can be in the form of publications, community forums, conferences, ways that are accessible to other people. So here's where we'll leave off for now, and I'll see you in a bit for more on planning.